Hello and welcome back to today's session. Today we zero in on a critical subset of hemolysis, that is autoimmune hemolytic anemia. This is a diagnosis of friendly fire where the body's own defensive system mistakenly turns on its vital fleet of carriers, the red blood cells. We'll use a tactical analogy to distinguish between the two major subtypes, warm and the cold AIHA. Okay, and let's stick on with our delivery truck fleet. But now the problem is specific. The city's security force has gone rogue. The force's two main surveillance divisions operate under different protocols, leading to two distinct types of attacks. The warm type, so this is the most common type of AIHA, accounting for 80% of the cases. The attack is driven by IgG security unit. Think of these soldiers as highly aggressive snipers who are active at body's normal warm operating temperature, 37 degrees Celsius. These IgG snipers coat the surface of the RBC trucks. They prefer to operate in the splenic surveillance sector, the spleen, which is a congested, warm environment. Macrophages, the demolition crew in the spleen, recognize the IgG coated as a danger tag. They attempt to remove these tags but end up taking the bite of the truck's chassis. And so here the forensic evidence, the partially repaired, damaged trucks lose their central pallor and become small, like rigid spherocytes. And Coombs test, the crucial test is strongly positive for anti-IgG because the snipers are still stuck to RBC surface. The warm IgG, the warm AIHA is often secondary to underlying lymphoproliferative disorders or autoimmune diseases. Like SLE, management relies heavily on corticosteroids and often splenectomy, like removing the primary demolition site. And cold autoimmune hemolytic anemia. This is a less common but often more dramatic form of AIHA where temperature is the controlling factor. The attack is driven by IgM security unit. Think of these soldiers as amateur sentinels who only become active when the temperature drops, typically below 30 or 32 degrees Celsius. The attack occurs in the cold peripheral circulation, fingers, nose, ears. The large pentameric IgM antibodies bind to the truck and immediately activate the complement system. The city's explosive demolition charge. When the truck returns to the warm central circulation, the IgM may dissociate, but the complement cascade has been initiated. This leads to intravascular hemolysis. The explosion charge, the complement, successfully ruptures the RBC, leading to the direct destruction in the bloodstream. This is why cold AIHA is more associated with acute, sometimes severe intravascular hemolysis. So here the forensic evidence, patients may exhibit acrocyanosis, that is the blue discoloration of the extremities when exposed to cold. And Coombs test is typically positive only for anti-C3, that's the complement component, and often negative for anti-IgG because the IgM sniper may be retreated when the sample warmed up. So cold AIHA is frequently associated with acute infections like Mycoplasma pneumoniae or infectious mononucleosis or chronic lymphoproliferative diseases. Management focuses on keeping the patient warm, treating the underlying cause, as in splenectomy is usually ineffective as the attack occurs in the circulation and not in the spleen. To summarize, the AIHA is differential. The warm type is IgG driven, splenic destruction is seen, leaving spherocytes. The cold type is IgM driven, complement mediated, that is intravascular destruction is seen, triggered by temperature and often leaving only complement on the RBC surface and no IgG antibodies. And that's it about the AIHAs.